Good afternoon, everyone. First question is for Dr. De Jesus. How do we confirm that elevated cardiac markers among CKD patients is not falsely positive?
Thank you for that question. Elevation of troponins has a lot of factors that contribute to the elevation of troponins. One of it will be CKD because of the decrease in the clearing time of troponins. So that means you might have an elevated troponin without any possible myocardial injury. To sort this out, diagnosing ACS would involve other parameters. You have to treat the patients with his or her clinical conditions, clinical history, and when you're doing examination. So you don't need to rely on just the troponins. As mentioned by Dr. Yambao, even a myocarditis may present with elevations in troponin. So how would you figure out which factor or which condition has caused the elevations in your troponin? So this is where other tests may come into the picture, meaning you can do you can also request for a 2D echo. You can also do a CCTA, meaning a coronary CT scan to check for any stenosis or blockage in the coronaries, as well as checking for doing a functional testing such as an MPI, like a myoperfusion imaging using a nuclear scan, or you can do a dobutamine stress echo. So you don't have to rely just on the troponin in making a diagnosis, but you have to understand also if there's elevating troponin, meaning once you get a troponin and repeat the troponin and the troponin is elevating after a few hours or after a few days, you might need to consider that this elevation in troponins may also be a sign that there is progressive damage of the myocardium, meaning there's progressive ischemia, progressive infarction. So those things have to come in your consideration when you're diagnosing or treating this patient.
Thank you so much, Dr. De Jesus. I would like to transition from your answer of that question to ask Dr. Yambao. Some of these advanced imaging modalities are not present in all of the hospitals, especially here in our third world country. So when you have an elevated troponin and as you discussed, there are similar symptoms also mentioned by Dr. De Jesus between myocarditis and acute coronary syndrome. In your practice po, will the 2D echo be sufficient, like the wall motion, or are there other, do you go clinical? How do you differentiate if it's really an ACS or a myocarditis, for example, related to COVID?
Thank you very much, Dr. Arman. So I think clinical factors should also be considered in differentiating whether it's myocarditis or ischemia. Okay, so or it could be both. It could be together also. It could. First is we check for the patient's vital signs. Make sure that the patient is not stable, or if the patient presents with hemodynamic instability, then and if it is a sudden onset, we might consider that there is an acute cardiovascular event. Then the 2D echo can also give us clues, okay, whether the patient has cardiomyopathy or we're dealing with coronaries. Like for example, if we have the previous baseline to the echo and the EF is really good, and we can then the recent now while the patient is hospitalized cause a sudden decrease in EF with global hypokinesia, then more likely we'll be dealing more with cardiomyopathy as compared to the patients present with segmental wall motion abnormality into the echo. And also from the 2D echo, we could also estimate the patient's cardiac output, and we could also estimate the systemic vascular resistance. And that would also give us clue. Like for example, if the patient is hypotensive, and then we also saw that there is decreased cardiac output and also increase in systemic vascular resistance, then more likely we're dealing more here with a cardiac cause rather and probably coronaries. more than dealing with sepsis as the cause of hypotension. So it's really a combination of clinical and also a diagnostic test evaluation. And from the ECG also, we can do serial ECG monitoring. And the myocarditis usually presents with a diffuse ST segment elevation. But if we could see segmental ST segment elevation or just affecting a certain territories in the coronaries, then more likely this is we're dealing with coronaries also.
Thank you so much, Dr. Yambao. For Dr. De Jesus, I noted that there were several questions regarding nitrates. Are nitrates always contraindicated in inferior wall myocardial infarction? And if nitroglycerin is useful in limiting infarct size, if there are studies related to that, doctor?
For most cases of inferior wall MI, it will be contraindicated because you might decrease the cardiac output by vasodilating by decreasing the preload going to the RV. So if you decrease preload, there'll be less cardiac output if there's an inferior wall MI. So I don't think there will be a role for nitrates in patients with inferior wall MI. I've seen cases with inferior wall MI without hypotension, but I still fear that if I start these patients on nitrates, they'll be hypotensive. So very difficult to manage with just nitrates. About the second question, there are small studies that say that introducing nitrates for MIs, specifically the MIs that's causing chest pains, will improve or decrease the size of the myocardial injuries in these cases. There are some studies that report that there'll be less elevation in troponins with nitrates, but they're very small studies. But most of these studies will just say that nitrates might not improve the outcomes of these types of patients, although their symptoms might be reduced. But starting them on nitrates, especially on patients with ACS, STEMI, will not give improve in outcomes in patients. But we've used nitrates in a lot of patients with ACS to relieve their chest pains. But with regards to mortality and morbidity outcomes, time of hospitalization, nitrates has not shown decrease in hospitalization rates as well as decrease in mortality and morbidity benefits. I've used nitrates in patients with MIs. I found them very, very useful in MI patients who are who are having heart failure, because they can decrease preload and decongest my patients with patients with heart failure and ACS. But as of now, guidelines will not give class 1 recommendations to patients. Nitrates as a class 1 indications for ACS, specifically the NSTEMI and the STEMI.
Thank you, doctor. There's a question here. I think this is related to the topic of viral myocarditis for Dr. Yambao. It goes like this. In a reversible heart failure disease, is there a possibility that the heart may go back to its normal size and functioning without further management?
Theoretically and based on the studies, it won't. That's why medical treatment is warranted for these patients if the patient already has viral cardiomyopathy. But that's a different story when the patient simply has a viral infection, because as I said, probably patients would have viral infection. It could affect the myocardium, but majority, around 70% patients will recover and would not develop cardiomyopathy. But in those 30% who develop cardiomyopathy, then treatment is really warranted for us to reverse or to really cause an improvement in the patient's cardiac profile.
Thank you, doctor. Why do people who are post-COVID asymptomatic still experience dyspnea and shortness of breath after recovery? Could this be related to problems, cardiac problems?
Dyspnea can be due to a lot of factors. It could be pulmonary. Probably there is a direct pulmonary insult because from resulting from the COVID infection. But it can also be due to cardiac reasons. And in patients with COVID-19 infection, the COVID virus, based on the studies that were investigated or were done in patients, they have either direct myocardial injury, or they resulted to the amounting to host immune response. The cytokines will cause immune response, and this would lead to chronic inflammation in the patient's myocardium. And chronic inflammation can lead to myocarditis and decrease in cardiac function, which could also play a role in patients having dyspnea.
Thank you, Dr. Yambao. Thank you.
The world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share, every second counts. Live integrated tele-ultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated tele-ultrasound collaborative platform. Philips Lumify. Integrated tele-ultrasound, powered by React's collaborative platform. Innovation and you, Philips.
For Dr. De Jesus, what are the indications for putting a patient on O2 support? Do we always do that? Is there a possibility of causing injury if we give oxygen in a patient who has an O2 sat that is adequate?
That's a nice question, Armand. Actually, the guideline which will say that oxygen is not actually required, not unless the patient O2 sat is below 90%. giving a patient more than the allowed oxygen in his body will not actually improve the condition, especially if the patient is having ACS or having a heart attack. Because in some studies, it showed that increase in the oxygen levels in the blood by giving supplemental oxygen will actually increase or might increase the risk for more myocardial injury. This is manifested as an increase in O2 toxicity. So some patients will have more injury if you put them on oxygen, if it's not really required. So it's actually a misnomer to put all patients with ACS on who are on ACS with oxygen unless they really have desaturations in their unless they have the desaturations. So make sure that you check the O2 sats before you put the patients on oxygen.
Thank you, doctor. Thank you. What is the role of heparin in acute coronary syndrome? When do we use it?
For unstable angina, STEMI, and STEMI, heparin is needed for its antithrombotic properties. So as you know, the mechanism of unstable angina and STEMI, they all will form thrombosis, or the platelets will have very, very high. There will be hyperactive platelets because of the plaque erosion and the plaque rupture. So in order to decrease progression of the disease, you can start the patients on low molecular weight heparin. In the States, they actually recommend using bivalirubin, but the outcomes will show that heparin might be superior with bivalirubin, especially on patients who are about to undergo reperfusion therapy such as a PCI.
Thank you, doctor. For this question, I think we can give it to Dr. Yambao as the cardiac rehab specialist. How and when do we start cardiac rehabilitation for patients who have undergone PCI?
The timing of resuming cardiac rehabilitation or physical activity will be guided initially by the patient's initial presenting symptoms and myocardial injury, as well as patient's LV function. So our criteria generally is if the patient is hemodynamically stable, so if he's not on any inotropic support, and the patient is awake, able to follow instructions, and the patient's troponin level is not increasing. So it may not normalize, but the trend should not be on going up. It stabilizes, or even the trend is going down. And there's no ongoing LV dysfunction. And with these patients, cardiac rehabilitation should be initiated.
Thank you, doctor. And here's something, I think this is a good question regarding COVID myocarditis. What are the recommendations for screening and following up patients who have been diagnosed with COVID myocarditis?
The recommendations, again, would depend on the patient's initial presentation. So if the patient has a severe LV dysfunction and also went into hemodynamic instability, it is recommended that you repeat again another 2D echo in 1 to 3 months. Okay, and also check for other parameters like troponin. And of course, aside from the cardiac parameters, look into the patient as a whole. Check for the blood chemistry, sugar, cholesterol, as this could also affect the recovery of the myocardium. And for more stable patients, we could repeat the 2D echo in 6 months. So it really depends on the initial presenting symptoms, and also during the course of the patient's recovery, if there are new onset symptoms, and we need to do the cardiac workup again.
Thank you, Dr. Yambao. What about for patients who have a concomitant platelet disorder, Dr. De Jesus? Will the management for these patients, if they have acute coronary syndrome, change if they have a concomitant problem with their platelets? Or do we still give the same therapy?
Well, that depends. Having a dysfunctional platelet will not mean that the patient, though there be an additional risk for them to bleed, but the fact that there's already thrombosis, that means their platelet might not be dysfunctional at all, because they have risks, just like anyone. They have risk for atherosclerosis as well as plaque rupture and plaque erosions in patients with MI. So the fact that they already form thrombus in the heart, there might be no contraindication yet for thrombosis or yet for antithrombotics. But actually, maybe the question is related to patients who are actively bleeding, who have problems with, who have bleeding disorders. Yes, that will be a major issue for us, especially if there's actively bleeding and the patient is actively bleeding and we have to intervene and do reperfusion or revascularization therapy. Our goal, as always, is to maintain or secure the blood flow of the heart. So even with a dysfunctional platelet or a bleeding problem, there's still a role for revascularization, though you might need to tell the family that there'll be things that you will have to sacrifice. More likely, if there's actively bleeding, more likely there'll be more transfusion. And if you're going to put a stent, there'll be a risk for more bleeding because you'll be requiring the patient to take dual antiplatelet therapy. To skip around that risk, what we can do for the patient as interventional cardiologists is just not to put a stent. What we can do is revascularize the patient using a drug-eluting balloon or just a plain old balloon angioplasty to open up the blood vessel. That won't entail putting a stent that increases the risk of early thrombosis for these types of patients. So that's what they do in the 90s and the early 2000s when stent was not yet available. In order to open up the vessel, what we can do as interventionalists is just do a balloon angioplasty. And then right now we have drug-eluting balloon, which works as good or maybe even better for patients who doesn't require to have a metal stent in their blood vessels.
Thank you, doctor. Thank you.